Good day, dear students. My name is Elena Mazyrskaya. I'm Associate Professor of Pediatrics Department number 2. The topic of the lecture is anatomical and physiological peculiarities of respiratory system in children, semiotics of common respiratory diseases. So, what are the anatomical and physiological features of nasal cavity in children? First of all, up to 6 to 8 months of age, breathing is carried out only through nose. Relatively narrow and dry nose, and the second one, anatomical feature. There is an insufficient development of the cavernous tissue of submucosa and lack of the lower nasal passage up to about 4 years old. The newborn has cells of ethmoid sinuses and maxillary sinuses. It is believed that ethmoid sinuses may be involved from 6 months of age, and the maxillary sinuses are pneumatized by 2 years. The sphenoid sinus is formed usually by the age of 5. The frontal sinuses begin to form at the age of 7 to 8 years old. Anatomical and physiological features of pharynx in children. Pharynx is relatively small and narrow. The lymphoid hyperplasia is common for the childhood. It is more prominent during the second, third year of life. The auditory tubes are wide, straight, short, and horizontal. Hyperplasia of lymphoid tissue on the posterior wall of the pharynx in children determines the possibility of the development of the pharyngeal abscess, and hyperplasia of the adenoid, tubal, and palatine tonsils often contributes to violation of nasal breathing and resonance of the voice, as well as frequent otitis media. Approximately at 7 to 10 years old, auditory tube location becomes similar as in adults, which causes a lower prevalence of otitis media in older children. The larynx in children is different from such in adults. First of all, it has a funnel shape, and in comparison, in adults it is cylindrical. It is located higher than in adults. In children, it is at the 4th cervical vertebra level, and in adults, it is at 6th cervical vertebra. The glottis is relatively narrow. The vocal cords are loose, and there is a lymphoid tissue in the ligamentous space. Lymphoid tissue and loose submucosal layer in the subglottic space explains the possibility of stenosing laryngotracheitis, also called false croup, and persists in children up to 5 to 7 years old. In addition, the lymphoid tissue of the subglottic space causes a high incidence of post-intubation stenosis of the larynx compared in adults. Here on the picture you can compare anatomy of adult airway and anatomy of a pediatric airway, and yet you can see that funnel-shaped larynx in comparison with cylinder-shaped. The lower airways begin at the level of 5-6 tracheal ring. Quantity of cartilaginous semirings of the trachea is constant. It is 16 to 20 and does not change with the age. Insufficient development of cartilage tissue promotes significant prolapse of the tracheal walls inward during breathing. The walls of the trachea in children are soft and easily can be squeezed. In adults, bifurcation of trachea is located at the level of 4th-5th thoracic vertebra, in children 3rd to 4th thoracic vertebra. On the front surface of the chest, cells had the following topographic landmarks. First, intercostal space is located directly below the clavicle and the first rib. The angle between the handle and the bodies of the sternum is called Lewis angle, corresponds to the place of attachment of the second rib. The lower borders of the lungs are crossed along the mid-clavicular line and 7th rib and along the middle axillary 8th rib. Mid-clavicular, 7 and 8. Topographic landmarks on back of the chest are the spinous processes, cervical and thoracic vertebra, as well as late angles. The upper borders of the lungs are located approximately at the level of the spine of the 7th cervical vertebra. The lower borders pass almost horizontally at the level of the spinals from the 10th thoracic vertebra. Borders between top and bottom lobes of the lung from behind pass along the line connecting the 3rd edge along vertebral line, which is located just above spinous process of the 3rd thoracic vertebra, and the 7th rib corresponding to the angles of scapula. The angle of the scapula is in the 7th intercostal space. The upper lobe of the right lung consists of 3 segments: apical, posterior, and anterior. Medial, 2 segments, lateral and medial. Lower lobe of 5 segments: upper apical segment, medial basal cardiac segment, which is located on the medial surface of the right lung and is not shown on the figure, as well as in front of it. Lateral and posterior basal segments. The upper lobe of the left lung consists of the same 3 segments as the right lung. The lower lobe includes upper and lower lingual segments, upper or apical segment, anterior, lateral, and posterior basal segments of the lung. In the left lung, the basal cardiac segment is not distinguished anatomically. Pathophysiological features of respiratory organs in children. The relative narrowness of the lumen of the respiratory tract. Imperfect mechanisms of mucociliary clearance. Insufficient development of the cartilaginous framework of the trachea and bronchi. High frequency of aspiration. High frequency of obstruction of the auditory tube. Propensity to develop bronchoobstructive syndrome. Now, complaints which are specific for respiratory diseases in children. Nasal congestion, runny nose, sneezing, cough, voice change, shortness of breath, chest pain, and hemoptysis are common complaints in children. General symptoms include fever, weakness, decreased appetite. Rhinitis. There are such rhinitis assessment parameters as acute, lasting up to a month, or chronic, more than 1 month. Amount of discharge, slight, moderate, and abundant. The nature and color of the discharge, mucus or purulent. The presence of pathological impurities, for example, blood. Allocations are observed from one or both nasal passages. Considering that children in the first 6 to 8 months of life breathe exclusively through their nose, The presence of any rhinitis leads to anxiety and refusal to eat. This is due to the fact that the child's epiglottis is in direct contact with the soft palate, which makes mouth breathing possible only at the moment of cry. Rhinorrhea from both nasal passages is a prerequisite for rhinitis of any etiology, infectious, allergic rhinitis, and unilateral rhinitis characteristic of a foreign body. The most common causes of nasal obstruction are swelling of nasal mucosa, polyps in the nose, curvature of the septum, and foreign bodies. Symptoms that increase the likelihood of bacterial infection in respiratory diseases. Febrile fever for 3 consecutive days with the presence of symptoms of damage to the respiratory tract. Febrile temperature during the day in combination with tachypnea, not appropriate for the fever. Repeated febrile increase in body temperature and higher on the background of respiratory infection. So these features, they are common for bacterial infection because most commonly the cause of infection or the respiratory disease in children are viruses. Cough in children is assessed by the following parameters. The cough can be dry or wet, so this is the type of the cough. The cough can be rare, frequent, and debilitating. It can be acute, subacute, or chronic. Mostly we make division of acute is less than 4 weeks and chronic is more than 4 weeks. The cough may be specific or it may be deep. We distinguish intensity during the day or during the night. We mention relationship of cough with vomiting. The presence of pain in the chest with coughing, typical for pleurisy, for example. Communication with a certain position of the body. Like for tracheitis or whooping cough, the horizontal position is common for a cough and for gastroesophageal reflux disease. And connection with physical activity, which may be a clue to asthma or to obstructive bronchitis, and so on. Physiological cough is often observed in children of first 5 months of life due to the onset of active function of salivary glands. So some have some problems just with swallowing of big amount of saliva. So this is not pathological, this is physiological cough. Clinical features of cough in bronchoobstructive syndrome. Cough is dry or slightly productive, and profuse sputum is not typical. Characterized by the presence of nocturnal or morning cough, chronic cough along the course, and worsening of cough during physical activity. So these features are common for some bronchitis with obstructive patterns or just for asthma. And you can see there is a difference in bronchs, in normal bronch and in asthmatic bronch. And these are the underlying causes of a difference of clinical picture. Clinical features of cough with postnasal drip syndrome. The cough is wet, unproductive or productive. Presence of nasal congestion. Increased cough in horizontal position. And periodically vomiting occurs in the morning on the background of cough because of big amount of sputum, as you can see on this picture. On this, these are postnasal drip. The cough during a whooping cough, it has prolonged duration, from 3 weeks to 2 months. The cough is paroxysmal with reprisals or with whoops at the end of paroxysm of the cough. It's a deep inhalation which is caused by a hypoxia developing during paroxysms of cough. The presence of repeated vomiting on background of cough, facial hyperemia and lacrimation with bouts of coughing, tilting the head forward with the cough, discharge of vitreous, wetness, mucus at the end of coughing attack. The inspection includes an assessment of the following parameters: the degree of impairment of consciousness, physical development of the patient, and appropriateness to age. These are important features of some chronic underlying conditions like cystic fibrosis, which leads to developmental delay in physical development, psychomotor development, constitutional body type, motor activity of the child, skin color and visible mucous membranes, respiration characteristics, frequency, amplitude, and rhythm, the presence or absence of clinical symptoms of dyspnea, signs of chronic damage of respiratory tract, drumsticks, chest deformity, emphysematous chest, and signs of pain. Internal examination of the nose is the next step of clinical exam of the child. Normally, the mucous surfaces are pink and the vestibules are patent and easily visible to the level of the middle turbinates. The septum should be in the midline. Also, a slight deviation is acceptable. Transient septal deformity secondary to in utero positioning may be noted in the newborn. The differential diagnosis of septal perforation includes infectious disease, inhaled drugs, particularly cocaine, and traumatic injury. Swelling, bleeding, abnormal lesions, and types of secretion should be noted. Nasal discharge. Thin serous or watery nasal discharge may be seen in patients with allergic rhinitis or a viral upper respiratory tract infection. An almost crystal clear nasal discharge can occur with leaking cerebral spinal fluid. A more viscous nasal discharge may occur during the later stages of viral upper respiratory tract infection, and thick purulent nasal discharge is typical for a viral or bacterial infection involving nasopharynx or sinuses. An impacted foreign body should be suspected in the patient with unilateral malodorous purulent nasal discharge. Here on the picture you can see nasal polyps and a gray or white mucoid masses, so their appearance in nasal cavities. If a newborn has an apparent nasal obstruction, the examiner should rule out the possibility of anal atresia by attempting to pass a small gauge, fitting tube, or French catheter through each nasal passageway. Occluded nasal passageways caused by boggy nasal mucosa may develop as a result of allergies, vasomotor rhinitis, or overuse of nasal decongestants. Nasal polyps caused by allergies or associated with cystic fibrosis may cause unilateral or bilateral nasal obstruction. Children with allergic rhinitis may display allergic shiners, as you can see, upon the eyes, and in general this appearance is called adenoid facies, resulting from long-standing mouth breathing. The feature of adenoid facies include a long, narrow face, narrow, upturned nose, short upper lip, exposed upper incisors, recessed lower jaw, and forward head posture. Visualization of the palatine tonsils generally is not possible until the child is 6 to 9 months old. Once fully developed, the tonsils remain enlarged throughout childhood. Tonsil size. Enlarged tonsils with exudate may be caused by bacterial infection of the throat, and tonsils with group A beta-gammalytic streptococcus and other infectious agents like diphtheria, Epstein-Barr virus. Tonsillar crypts can harbor bacteria. Calcified concretions of bacteria, mucus, and other debris may form within the crypts and are called tonsillar leads. Tonsillar asymmetry or unilateral tonsillar enlargement may be caused by infection, chronic inflammatory process, or neoplasm, particularly lymphoma. Tonsil size is most often described on a scale from 0 to 5. So, 0 tonsils are within tonsillar pillar or previously removed by surgery, so they are not seen. 1. Tonsils occupy less than 25 of the lateral dimension of the oropharynx as measured between the anterior tonsillar pillars. Solid yellow arrow. 2. Tonsils occupy from 26 to 50% of lateral dimension of the oropharynx. 3. Tonsils occupy from 51 to 75% of lateral dimension of the oropharynx. And 4. Tonsils occupy more than 75% of the lateral dimension of the oropharynx. Infectious causes of tonsillar asymmetry include peritonsillar cellulitis or tonsillar abscess. Associated clinical features include severe sore throat, fever, or muffled voice, drooling, trismus, and neck pain. And you can see on the picture bulging of the soft palate and increased tonsillar hypertrophy on the left. Next, we go to inspection of the chest, and we pay attention to the form of the to the shape of the chest, and which one shape is very important. This is a barrel-shaped chest. So what its features are? It is increase in anterior-posterior dimension of the chest, increase in intercostal spaces, raising the upper shoulder belts, hypertrophy of both sternocleidomastoid muscles, and the short neck effect. It may occur due to some congenital conditions and mostly which lead to chronic insufficiency of air and chronic some obstructive disease. The next step is breathing assessment. Observation of breathing pattern is foremost in the examination of the lung. The rate, rhythm, the depths of breathing should be noted. A periodic sigh is normal in every one child. Shallow, rapid breathing can be seen with anatomical defects, pulmonary infection, pleuritic disease, and metabolic disorders. Slow breathing may occur as a result of central nervous system pathology, metabolic disease, and drug effect. Deep rapid breathing may be caused by vigorous exercise, anxiety, and metabolic acidosis. A prolonged expiratory phase occurs in patients with an acute or exacerbation of reactive airway disease or asthma. Rapid breathing, alternating with respiratory pauses, may occur in sleeping infants. Auscultation. Auscultation may help localize a particular area of involvement or specific pathologic condition. Ordinarily, deep mouth breathing produces clear, soft breath sound over the lungs. Atypical breath sounds in the form of crackles, rhonchi, or wheezes are heard most often in patients with underlying pulmonary disease. Upper airway congestion in small children often produces coarse sounds that, when transmitted through the larger airways, may give the impression of an underlying lung abnormality. Frequency, coughing, and/or vigorous crying will clear a congested upper airway, helping the clinician distinguish between upper and lower airway sounds. In small children, an inspiratory high-pitched stridulous sound with or without significant respiratory distress may be the result of narrowing at or near the larynx or anywhere along the trachea. This condition can be caused by a croup-like illness, anatomical defect, mass lesion, foreign body, or external obstruction. Patients in severe respiratory distress with stridor may have epiglottitis or croup. When absent or decreased breath sounds are heard over a particular lung area, spoken words may sound muffled or the letter E may sound more like A. This is called egophony, especially in a child with segmental or lobar consolidation. Early, well-localized squeaky crackles during respiration may be caused by a pleural friction rub. The clinical picture of IRV is determined by the type of virus that caused the disease. The influenza virus predominantly affects the epithelium of the trachea. Rhinovirus affects nasopharynx. Parainfluenza virus larynx and trachea, and so it leads to laryngotracheitis. Adenovirus have a high affinity to mucous membrane of eyes, tonsils, and trachea. So then the main clinical features of the influenza will be tracheitis, sometimes accompanied by bronchitis. Of rhinovirus, it will be rhinitis. Parainfluenza, it will be a laryngotracheitis. Adenovirus causes conjunctivitis, first of all, pharyngitis. The main clinical symptoms characteristic of RV are usually rhinorrhea, cough, fever, sore throat, and hoarseness of voice. With stenosing laryngotracheitis, inspiratory dyspnea and stridor are observed. So the symptoms of IRV are repeated high fever after a few days of normal temperature. So these are complications of IRV. The high fever, the appearance of shortness of breath, a pain when opening the mouth or turning the neck, ear pain or swelling of the neck, common for otitis media and lymphadenitis, unilateral edema of the paraorbital tissue for sinusitis, and otorrhea. Laryngeal stenosis usually occurs in laryngitis from the first day of illness till the fourth. In later periods, the likelihood of its occurrence is very small. Laryngeal stenosis occurs as a rule at night. The degree of change in voice from harshness to aphonia correlates with the severity of the degree of stenosis of the larynx. There are 4 degrees of acute stenosing laryngotracheitis: compensatory, subcompensatory, decompensatory, and asphyxia. At the first degree of stenosis, there is a catarrhal syndrome, fever, barking cough, hoarseness, and inspiratory stridor. At rest, inspiratory shortness of breath is absent. In half of the cases, this stage of the disease occurs very briefly, several hours, or may be absent. The second degree of stenosis is characterized by the presence of inspiratory dyspnea, even when the child is calm without any physical activity. The child is restless, there is a frequent dry cough, breathing becomes more noisy, the respiratory excursion increases, retraction of intercostal space and jugular pits is clearly visible. The stage of decompensation, the general condition of the child is severe. The child is agitated, takes a forced sitting position, the skin is pale, perioral cyanosis is observed. Inspiratory dyspnea is pronounced and is accompanied by a retraction of the sternum. In this stage of the disease, the cough is reduced, there is a disappearance of the voice up to aphonia. Stridor. Stridor is a common symptom in patients with croup. Stridor is an audible, harsh, high-pitched musical sound on inspiration produced by turbulent airflow through a partially obstructed upper airway. This partial airway obstruction can be present at the level of the supraglottis, glottis, subglottis, and/or trachea. During inspiration, areas of the airway that are easily collapsible, supraglottic region, are suction closed because of negative intraluminal pressure generated during inspiration. These same areas are first opened during expiration. Depending on timing within the respiratory cycle, stridor can be heard on inspiration, expiration, or in both. It is called then biphasic, expiratory and inspiratory. Inspiratory stridor suggests laryngeal obstruction, whereas expiratory stridor suggests tracheobronchial obstruction. Biphasic stridor indicates either subglottic or glottic anomaly. An acute onset of marked inspiratory stridor is the hallmark of croup. However, concurrently, there may be a less audible expiratory stridor. Young infants who present with stridor require a thorough evaluation to determine the etiology and, most importantly, to exclude rare, life-threatening causes. Also, croup is usually mild, self-limited disease. Upper airway obstruction may cause respiratory distress and pose risk of death. Bronchitis. Acute bronchitis is a clinical syndrome produced by inflammation of trachea, bronchi, and bronchioles. In children, bronchitis usually occurs in association with viral lower respiratory tract infection. Acute bronchitis is rarely a primary bacterial infection in otherwise healthy children. Symptoms of acute bronchitis usually include productive cough and sometimes retrosternal pain during deep breathing or coughing. Generally, the clinical course of acute bronchitis is self-limited, with complete healing and full return to function typically during the 1 to 2 weeks following symptom onset. Lungs may sound normally, but crackles, rhonchi, or large airway wheezing, if any, tend to be scattered and bilateral. Acute bronchitis begins as a respiratory tract infection that manifests as a common cold with chills, with malaise, sore throat, muscle pain. The cough in these children is accompanied by nasal discharge. The discharge is watery at first, then after a week becomes thicker and green. then becomes clear again and has a mucoid watery consistency before spontaneous resolves. Initially, the cough is dry and be harsh or raspy sounding. The cough then loosens and becomes productive. Children younger than 5 years old rarely expectorate. In this age group, sputum is usually seen in vomitus. This is called posttussiphimosis. Parents frequently note a rattling sound in the chest, hemoptysis, a burning discomfort in the chest, and dyspnea may be present. Bronchiolitis is an acute inflammatory injury of the bronchioles that is usually caused by a viral infection, most commonly respiratory syncytial virus in children. This condition may occur in persons of any age, but severe symptoms are usually evident only in young infants, as seen on the image on X-ray below. Signs and symptoms. Because bronchiolitis primarily affects young infants, clinical manifestations are initially subtle, such as the following. It may become increasingly fussy and have difficulty feeding during the 2 to 5-day incubation period. Low-grade fever, possible hyperthermia in infants younger than 1 month. Increasing coryza and congestion. Apnea may be presenting symptom in early disease. Severe cases of bronchiolitis may progress over 48 hours to the following signs and symptoms. Respiratory distress with tachypnea, nasal flaring, retractions, irritability, and possibly cyanosis. Pneumonia. Pneumonia is an inflammation of lung tissue of usually bacterial origin but also may be viral. Pneumonia can occur at any age. Nevertheless, it is more common in young children due to some anatomical and physiological peculiarities of bronchs and lung tissue in children. Newborns with pneumonia commonly present with poor feeding and irritability, as well as tachypnea, retractions, grunting, and hypoxemia. Infections with group B streptococcus, Listeria, Klebsiella are common causes of bacterial pneumonia. For uterus in utero, transmission is most common cause of group B streptococcus. The most commonly isolated virus is respiratory syncytial virus in children. Cough is the most common symptom of pneumonia in infants, along with tachypnea, retractions, and hypoxemia. This may be accompanied by congestion, fever, irritability, and decreased feeding. Viruses are the most common cause of pediatric pneumonia. Streptococcus is the most common bacterial pathogen in infants aged 1 to 3 months. On this slide, I want to show you some percussion, auscultation, and clinical features of some common syndromes of lung injury in children. So, pleural effusion. It is accompanied by decrease in breath sounds, dull percussion sound, decrease in fremitus, and no tracheal deviation. Atelectasis. It is a consolidation of the lung and collapse of the lung. It is accompanied by decrease in breath sound, dull percussion tone, and dull fremitus, and there can be nothing to auscultate at this region. Simple pneumothorax is accompanied by decrease in breath sounds, hyper-resonant percussion tone, and decrease in fremitus, no tracheal deviation. Tension pneumothorax is accompanied by decreased breath sounds, hyper-resonant percussion, decreased fremitus, and tracheal deviation will be away from site of lesion. Tension pneumothorax, decrease in breath sound, hyperresonant percussion tone, decrease in fremitus, trachea away from site of lesion. Consolidation, common for lobar pneumonia and pulmonary edema and so others pathology, is accompanied by bronchial breath sounds, late inspiratory crackles, egophony, whispered pectorally, dull percussion, increased of fremitus, and no tracheal deviation. The natural history of lobar pneumonia consists of 4 stages. The stage of congestion is during the first 2 days of the disease. There is a red-purple partial consolidation of parenchyma, exudate with mostly bacteria. Second stage is red capitization during 3rd, 4th day. Red-brown consolidated, exudate with fibrin, bacteria, and red and white blood cells. The next stage is gray hepatization, 5 to 7 days of disease. Uniformly gray tissue exudate full of leukocytes, erythrocytes, and fibrin, and the stage of resolution after 8 days. Enzymes digest components of exudate. Now it's time to conclude this lecture. On this slide you can see the literature on the basis of which this lecture was done, and this literature you can use for further reading. And I thank you for your attention.